Hey, good evening, everybody, and welcome to this webinar. My name is Matt Birtwistle from FND Hope UK. Very pleased to be able to welcome this evening Dr. Tim Nicholson. Tim, welcome.
Thanks, Matt. Welcome, everybody. Thanks for inviting me on.
Just to get us started, it'd be interesting to hear just what the last 12 months has been like within your world. I know we've been working together on a number of things that are quite important for FND, but what's the last 12 months been like for you?
Very busy, but also sort of lots of progress, I guess. So I'm currently a consultant neuropsychiatrist at the Maudsley and King's College Hospitals, where I run a specialist FND clinic, particularly for people with severe intractable motor problems. But I've also been running some studies, particularly a trial of transcranial magnetic stimulation, which has just completed its first phase, the sort of feasibility part of it. But I guess I've also been doing some things behind the scenes with everyone at FND Hope, and there's lots of encouraging progress, really, particularly with the application to NICE, hopefully with the aim of getting some NICE guidelines for FND, but also lots of other sort of aspects of raising the profile of FND in general public, amongst all clinicians of every type, really, and also doing a lot of education. I do a lot of teaching on various courses in London, particularly King's College London, but also UCL and various other institutions. And I guess we're still within 12 months of the big FND conference in Edinburgh, which was incredibly successful and a bit of a landmark moment for the disorder, I think. And the other thing that was bolted onto that we did the day before was something that Bridget was present at, which is a sort of first ever international meeting of professionals pretty much about anything in FND, but we were really focusing in on outcome measures for use in clinical practice, but more specifically using them for research as well. So how should we measure improvement and outcomes, and and obviously the role of patients in that is going to be critical. And we've kicked on we're just applying for ethical approval to start a fairly big study of patient views on and carers' views on outcome measures, because regardless of what we think as clinicians, I think it's going to be what patients and their carers think as the relevant outcomes is going to be at least as important.
Yeah, I'll just take you back a little bit for those who don't understand what NICE is. Perhaps you can just give a quick explanation of that.
Sure. Yes. So NICE is really this organisation in the UK. Well, it's just actually England and Wales. I think Scotland has its own system, but it's really a way of assessing, hopefully as neutrally as possible, what the best treatments are for different disorders, and also critically in this day and age of what's cost effective. So whether an intervention is not just effective, but it's actually sort of worth in our days of rationed healthcare, that it's actually worth the money spending on it. So there's enough improvement per pound spent for it to be worth investing in. So it makes those decisions, and it's open to stakeholder input from patient groups, but also every relevant sort of body, both clinician and otherwise, as well, in terms of deciding these important things and developing guidelines for treatment, which obviously we're sorely missing in FND.
Yeah, and I think that certainly is the big aspect, isn't it? That's probably going to be most observable by people if we're fortunate enough to get these guidelines created, is that it's setting out the process or the protocol for how GPs, clinicians, nurses, anybody within the medical field will then interact with patients who present with FND, which is something that we don't have at the moment. We don't have that consistency, do we?
No, and until relatively recently, we haven't had a vast amount of evidence to guide us in treatment, but there is some, and hopefully we're really accelerating and things are taking off. And I think there's lots of encouraging signs across the board in FND that we are finally getting our act together. And it's not, and I think it's really because the disorder's fallen between the gaps over the years, and it's great that we've got a interested bunch of clinicians, and you guys are all doing amazing work at educating everybody, and particularly commissioners and sort of politicians about this disorder.
Yeah. Okay. But as I say, it certainly has been from our perspective, what we've seen has been very productive, but it's also encouraging to get your insight onto that. Just for everybody that's in the chat and watching on Facebook, please get your questions in. We'll start getting some of those across to Tim very, very soon. So start firing them in now. But what I just wanted to pick up on a comment you just made then, Tim, was how FND is in the past has fallen between the cracks of neurology and psychiatry. And we spoke last Friday on Awareness Day with a lot of neurologists. Today's the first opportunity really to speak to someone who's as specialised as yourself. So how now is that gap closing between psychiatry and neurology?
Well, I think I guess it's really that we're all joining up to plug that gap, and also there's always been a few clinicians who've got sort of either dual training in both areas or particular interest in the overlap areas. So there's always been a few people, but we're sort of getting firstly more people interested, and I think that's particularly been there's always been a bunch of psychiatrists interested in this, but there haven't been many neurologists, and I think that's where people like John Stone and Mark Edwards have been particularly important in having some very proactive neurologists, not only doing research and advocating for these patients, for FND, but also educating their colleagues. And I think that's been critical, that this is not just something that once it's diagnosed by neurologists, it's passed on to psychiatry. It's also realizing that it's perhaps not just one discrete illness. It might be a sort of group, a cluster of similar disorders, some of which may have sort of psychological components, others of which don't. So I think it's really appreciating that complexity. And I think the research behind that has only really been sort of nailed in the last sort of few years, in fact. And it's the review that by Leah Ludwig and colleagues, which included John Stone, Alan Carson, myself, and several others, where we reviewed the number of patients for whom stress seemed relevant either in the whole lifetime, but also in perhaps precipitating or being relevant around the onset of symptoms. And really it is higher than with other disorders, but there's many people for whom it isn't the case. And that has always been a poor area of research. And we finally sort of done some studies in that area and put them all together and synthesized the data out there and sort of shown that. So I think that's a good place, because there are patients for whom seeing a psychiatrist is going to be important, and for others it's not going to be important or even relevant sometimes. So I think that's critical.
Yeah, and it's interesting. Just over the past few days, people have been posting on Facebook where their experiences have been. They've gone to the GP, or they've had another professional, but it's still very much the old way of looking at things, saying, well, you do need that psychiatric evaluation. There's nothing we can do for you. That's the place that you should go. But what you're saying now is with the evidence, and particularly the research that you've done, because it is still so new, but that is able to change the way the professionals will think. It's just going to take a long time, isn't it, before that?
Yeah, it does. And there are, and I think we're quite lucky in the UK and several other countries where that message has got across to the vast majority of neurologists. And I think neurologists are feeling comfortable at not only diagnosing and knowing that it's their responsibility to diagnose, because obviously the emphasis has gone from finding stresses that are related to actually finding the positive neurological symptoms, as I'm sure has been covered many times with John and others on these discussions. But it's then actually not just thinking, well, this is something to pass on to somebody else as a disorder. It's, well, I'm going to manage this and I'm going to take responsibility, and it's part of my job as a neurologist to help patients. And then critically, we also need services locally for every neurology centre so they can treat people effectively, and that's specialist physio, as we know, and also specialist psychiatry and psychology if and when relevant as well.
Yeah. Yeah. Okay. Well, we've got a few questions starting to come through, so I'll start firing these at you, Tim. The first one is from an anonymous attendee,
Mhm.
but they've asked, how does childhood trauma affect FND? As I was told, that might be the cause of my FND, but the emotional abuse I had was over 25 years ago, and my FND only came after having back pain a few months ago.
I think that's a brilliant question, actually. So for those who do have childhood traumas, I guess we also have to be careful in that, sadly, childhood traumas are pretty common. It's not when people do sort of epidemiological surveys of the whole population that, these sorts of things happen between 5 and 10% of the population, sometimes higher, depending on what, sort of things you use to measure this. So I think we always have to be slightly careful at assuming that things are relevant just because they're there. But we do find this overrepresentation of such things. And why there's that big time delay is a fascinating question. I think there's two aspects to that. I think there's the fact that I think most people would guess, and there's some evidence for it, that something about those traumatic experiences sort of resets your stress response and your brain's response. So the sort of endocrine sort of hormonal response. So there's some good evidence from some Dutch researchers about having childhood adversity affects your cortisol responses. So how the sort of general cycle of cortisol in your body, and also how it responds to stress. So there's something that might be changed as in a response to trauma, and so that's and that might be adaptive in certain situations. It might prepare the mind and the body for more trauma, or be a response at coping with it. But then somehow that sets you up to later on perhaps develop FND, and that's the sort of $1 million question we don't understand, is what is it that then makes you more likely to develop FND in the future. And when I did some research looking very carefully at the year before onset, we found that for some people there was something that reactivated that abuse. There might be when you look very carefully, some subtle thing that might have come out in that year. For an example might be that there's a family reunion, and there's somebody at that going to be present at that reunion who was sort of either involved, there was some reminder of that abuse, and that can somehow, I think, get the whole prime the stress response system in a way which is understandable. But how that then links into developing FND is another matter. But I think the other great point about that question is talking about getting some back pain or getting some physical, because I think that's where most FND comes from. There's some sort of organic start to it, and then the attentional processes, as we've seen from Mark Edwards' theories and others, of how the attention onto an organic physical symptom sort of almost makes it have a life of its own on top. So the sort of functional overlay on top, and in fact most cases might well start with something like that. So there needs to be a certain combination of factors. There's perhaps the childhood trauma in the past, something around the time priming the system, and then the physical disorder. It could be a flu-like illness, or a fall at work, or some other unusual bodily symptom that you focus on, and then from that the FND may grow. And I think that makes some sense, although we don't have a lot of evidence to sort of complete that overly simplistic story at the moment. But I think that's a sort of working hypothesis that most people would probably think is our best guess at the moment.
Yeah, and that certainly seems to be the case when you look through, again, within our own patient community and the questions that get asked, and that is such a common thing where something, and it doesn't necessarily that something's happened, emotional abuse or any other sort of abuse, but something happened a long time ago. And they felt that they dealt with it, but then some years later something else springs up, and as you say, it's that there is obviously something there, even if we can't quite put our finger on it. There's certainly enough hearsay, as it were, or things to say, there's definitely something going on here.
Yeah, exactly. And I think there can be other, it's not the same. I think that's where it's so different in every individual. I think, there's almost like, people, the story we hear a lot is that people are, the story I hear a lot is of people who are very much copers and people who look after other people. So they're always focused on caring for other people or looking after other people. And it's only when they stop that the world and their past catches up sometimes. And sometimes there's some event or something that's happened, like getting ill yourself physically, or perhaps having an operation, having an anesthetic, where things have been put behind you, but then suddenly they catch up at some point. So I think that's it. There is there are certainly quite a lot of patients for whom either being ill or having an anesthetic or something can bring that up, can bring on or FND occurs not long around that time, or sometimes exactly at the time of an anesthetic as well.
Yeah, and particularly if those people are, as you just said, if they're the strong ones, normally they're the ones that normally can cope with everything.
Yeah, not used to looking after used to looking out for themselves or paying attention to when they might be, physically and mentally sort of running out of steam, as it were. Because I think life is tough for everybody, and it's sometimes if you're just so used to not looking after yourself that you can sort of these things can happen.
Yeah. Okay. Well, we'll grab some more questions. Now, I saw this one. It was interesting because they mentioned TMZ, which obviously is part of your work as well. So, here it is. I just found it now. It's Denise. She said, if TMZ can help, could other magnetic fields in the environment be a trigger for some sensitive individuals?
I think my inclination would be that it's unlikely. I think there's certainly no evidence that magnetic fields can cause FND, and I think the way that we're using TMS, so it's transcranial magnetic stimulation, is really, so for those who are not aware, it's when you place a magnetic coil just on the rest it on the head, it can stimulate the underlying brain tissue, and so even though it's not a large amount of magnetic pulse, it's enough to create electrical current under the skull and stimulate the brain in the inch or two underneath the skull. And importantly, for the way we're using it, we're targeting the motor cortex, so the bit of the brain that controls the movement of the limbs. And we think that it's perhaps getting the limbs to move again is important. So I think sort of smaller magnetic fields that might be present within the world, we don't really have any evidence they could be causing it. It's really using it to sort of almost sort of jumpstart the motor system, as it were, and an ability to relearn normal movement again, which has been lost. But we don't quite know why that classical feature of FND, that inability to get the signal to the limb to go, and the harder you're trying, the harder the worse it is. So there's something about that initiation and planning of movement that's gone wrong. And that's where some of the functional imaging studies that I've done and other people have done have looked at what's going wrong. And we think there is these problems in sort of motor planning areas or motor initiation areas that also interestingly have links to emotional centers like the amygdala. So supplementary motor area has quite close links and can be influenced perhaps by emotion. So for some people, that's maybe where the emotion is interacting with the motion, as it were.
Yeah, I'm glad you mentioned about the functional MRIs. Again, it's another topic that's cropped up quite a lot these days. So just talk to us a little bit about your work in that area, and just help clarify as well what does a functional MRI do. I think we need to make a distinction between obviously how you would use as a tool for research versus helping diagnosis and relevant to that.
Yes, exactly. I think the so the functional MRI distinguishes it from the structural MRI. So structural MRI is purely just looking at the white matter tracks, the grey matter, and what volume it is, how dense it is, and looking normally for signs of overt damage. So in MS, that'll be sort of moth-eaten areas within the brain. A stroke would be a big clot or a hemorrhage within the brain. But the functional MRIs are looking at how much, essentially it's a sort of marker of how much oxygen the brain is using. And that's correlates highly with activity of the brain. So if you're using a bit of the brain, so whilst I'm looking at lights or hearing a sound, the various bits of my cortex that are involved in light or sound processing will be using up more oxygen and therefore showing up brighter on the MRI scans. But it's quite a complex sort of methodology of determining that, and it's rarely able to distinguish things in an individual. It's something that you need to get a group of patients and a group of controls, or a group of patients doing one task and then compare them to not. So again, listening to music versus silence and seeing what's different. So it's quite a sort of statistically complicated process, sort of working this out. So it's really using differences in that oxygenated blood has compared to deoxygenated blood in an MRI scanner. So it's quite a sort of complex process. So it's normally used for groups, and it used to be you need to compare 15 patients to 15 controls, but it recognised that you perhaps need quite a lot more now, and this is where we need to go with larger studies looking at groups of patients, and it's quite an expensive tool as well, and it's very time consuming for researchers and indeed patients to take part in this. And the other problem is you need to be safe to go in a high strength magnetic field, and if people have had operations in the past, which many people have, or there's any claustrophobic or couldn't tolerate being in a noisy scanner for sometimes up to an hour or an hour and a half sometimes, it means that not everybody can tolerate that or be safety approved. And there's a different threshold of safety for doing research scans compared to doing a clinical scan, because in a clinical scan, even if there's a trivial risk of something going wrong, you accept that on balance that's fine. But if it's for research purposes, the bar is set very high. So if there's any slight concern it's not safe, you're not allowed in the scanner. So it's a complicated sort of tool. But we've looked at it in lots of other groups, Mark Hallett's group, and which include Valerie Voon, who's now in Cambridge, done some great work, and various other centres as well. But we're just really starting out with that and looking at the different brain areas. But there is some consensus about these sorts of areas that I've been mentioning, the supplementary motor area, and the amygdala and emotion processing centres, and some frontal lobe structures perhaps as well. But it all depends on the exact experiment design, which areas you might expect to find. But I think most research would be considered quite preliminary, because until it's been replicated and using large samples, it should be considered a sort of preliminary finding. So I think we're at that sort of stage with this complex task. But I think the important thing to mention about it is that it's I think we often see that fMRI studies are misinterpreted as showing that this means it's a sort of neurological disease or something like MS or something else, but it's really just really the activity of the brain, which would change, if I'm thinking about, my favorite football team or something, so it's really brain function rather than any sign of any disease per se in the brain. But as we all know, these FND is a problem of the brain and a severe sort of software problem of the brain, and we always use that analogy. But I think it's important not to take an fMRI study as a sign that it's that this is we found that the cause of it is this particular bit of the brain. It's sort of more complicated than that.
Yeah, and for people watching as well, I think it's important to remember that you don't need an fMRI in order to make a diagnosis of FND.
Yes, and nor could it really be used for that. At least there's no one's sort of although I think that we have seen some preliminary data from a lab in Switzerland showing that it might be that if you take enough patients and look at the way when they're doing nothing, so just resting, that there might be a difference in connectivity of the brain that might be a signature of FND, and it might be in the future that it could be it's theoretically possible it could be used in the future, but at the moment there's nothing like the evidence to use it to distinguish between FND and healthy subjects or people with other conditions.
Yeah. Okay. Well, we'll go and take some more questions. Stephanie's got one for us here. She says, if you have a toolbox of CBT skills that you've already acquired from treatment after a trauma many years ago, yet the FND seems to be migraine based. Is there a way that you at home can see, test to find any current possible stresses so you can then manage those better? So I think what she's asking there is, the tools that she's previously learned, can she bring them to bear?
Yeah, I guess it very much depends on the individual case, but there are, I think if it is if someone does have a trauma-related illness, then I think quite possibly they could be the same tools, whether that's sort of recognizing the links between certain sort of emotions and times when the symptoms might come on, and noticing that the symptoms are starting and finding a way to sort of almost relaxation techniques or something that can allow you to sort of short circuit an emerging symptom, then that could well be the case, because I guess most people have multiple symptoms, and in fact I think practically all patients I see have at least a handful, and often two handfuls of symptoms that are often severe, and symptoms can jump around from one, the most serious one can often change. So I think that's often the case. You might apply the same tools to different symptoms, and the same could come over time, as it were, if you had symptoms in one area in the past and now it's a different type of problem. And I guess most clinicians would probably say that functional symptoms in one part of the nervous system, or even indeed one part of the body, are often related. It's the same sort of underlying process probably that's happening. So I think definitely it would be potentially applicable once you've learned certain techniques. They can be applied to different symptoms. Yes.
And for those people that have had CBT in the past but didn't find it successful,
yes,
that can often be a barrier for wanting to see, or even being willing to go and see a psychiatrist.
Yes.
What's your response to those individuals?
Well, I think there'd be two main responses, which would be, firstly, is to look into the type of CBT that they've had. I think if they'd had specialist FND therapy by an experienced therapist, then I think you're mostly looking at a type of patient for whom CBT is not going to be effective. The only small caveat in that is, I think, as with all psychological therapies, it's quite often a big part of it, even in CBT, is the relationship you have with the therapist, in that you feel that they understand you and your symptoms, and you get on and you work together on the symptoms. And I think, as with all human interactions, there's people you get on with and people you don't. And I think, even if it's sometimes an experienced CBT therapist or someone applying evidence-based CBT, there might still be the odd interaction for whom that therapist isn't the right one for you, and it's slightly more so user dependent. And obviously a medication is a medication, so it doesn't matter. But surgery, you could say, is the same. Some surgeons might have a technique or a style that suits you and your body, as it were, and it might be the same for a therapist. So but I think what we see more often is that people have had counselling or some lower level psychological therapy from somebody who isn't particularly trained in FND, and we're only just beginning to work out the evidence base that it works, and it is one of our the best treatments as far as we know at the moment, particularly for seizures. But we don't know what the active ingredient is. CBT is quite a broad church, and it can be applied in different ways, and each therapy session is slightly different, even though in trials they try and make it as sort of homogenous and the same type of thing as possible. It's even within that, there's quite a lot of variation, and it's only with lots of research that we'll better work out what it is about a particular therapy that might be working, which bit of it is the active ingredient, as it were, because we all know that sitting and talking to someone who's nice and sympathetic and listen, that can be helpful for anything, but it's really, what is it beyond that that's helpful? That's what we don't quite know. So just rambling a bit, but to summarize it, I think, I think the, for some people, I think it's because they haven't had a specialist CBT, and I think for others, it's probably that it might not be, you might not have a type of FND that's responsive to CBT. But I think it's worth trying a second therapist sometimes, particularly if you felt that you didn't sort of gel with that therapist or get on or that you felt that they really understood or cared about your problems, which hopefully most would.
Yeah, I mean, I can certainly understand where a little bit of that thinking would come from, because if you think about, the ways that a GP would refer you to counselling, or you could self-refer it in many counties now. You can do that yourself. But obviously, the people that you engage with on that counselling, they can be very young.
Yes.
They've just come out of a college course. You wonder about their life experiences as well. So I guess the key thing there is that if you've had that experience, the specialised CBT that you get in relation to FND is going to be dramatically different.
Yes.
Yeah. In fact, there is somebody here that's asked a kind of related question. Again, this one's anonymous, but they've said, I was told ill health brought the FND need on, but I've experienced 2 traumas as an adult in the past 21 years, and I knew after the first trauma I needed some talking therapy to help process it. I feel I need help with this. What type of person should I see? Should it be a psychiatrist, a psychologist, or even some counselling? Somehow I don't think counselling will get it, which just goes to what we're talking about.
Yeah. I think a lot of counsellors would feel out of their depth with this sort of case, and sort of rightly so. So I think it would be, almost, I don't think it's necessarily appropriate for a counsellor to be referred a complex trauma case, particularly when there's FND associated with it. So I think, and I think most counsellors would put their hand up and say, I don't think this is something I can deal with. Although, in certain fields, there's probably a handful of counsellors who have got a lot of experience over time with these sorts of cases. But I think really most people treating this, if it's CBT, will be a psychologist. And this is where the terminology gets a little bit confusing, because most CBT will be delivered by psychologists, although other professionals can be trained and deliver it, both doctors and nurses and other professionals as well. And then most psychotherapy is from a psychiatrist, but there are other psychotherapists as well. And I think that's the area that's hasn't really had so much research, although historically, obviously, it was sort of quite a big part of treatment, in the past. I think I think what we'd call psychodynamic psychotherapy, so the more sort of looking into traumas and childhood and what might have precipitated it, which tends to be a longer, less focused. It can go wherever it needs to go according to the patient and the therapist's sort of how it develops. Almost, it's slightly more, let's just explore what's there and see what comes out and how to deal with it. So I think if there is recognised trauma and it's felt to be relevant either by the clinician or the patient, and ideally both, then I think a sort of something beyond CBT can be helpful. CBT can sometimes touch on those aspects, but it's not. It's always much more about the here and now and how your symptoms are and your thinking is. So I would say that really the best gatekeeper would be a psychiatrist who specialises in FND, and they can assess your symptoms and what the stresses and traumas might be, and then sort of refer you on to what whoever's the most appropriate local therapist. And this is where the problem is, that we have quite a big discrepancy in availability of different types of therapy depending on where you are in the country, and that's where this is where one of our big goals is, I think, for everybody in the field, whether it's clinicians or patient groups such as Matt and everybody, is to try and get an equity of service provision across the country. And that's where things like these NICE guidelines, if developed, can really help, because then it's like, well, this is what's recommended, so every area must provide that, because it's not fair to sort of say, well, you can't have it, it's not in your area, or you have to travel to London or Edinburgh or somewhere else when you're 3-4 hours train drive and you're very disabled. To expect you to somehow get to therapy once a week is nigh on impossible. So I think yes, and obviously I'm very happy to, as part of one of my other roles, is helping out with the FN Forum, so a sort of group of professionals in the UK and then in fact internationally. So if people want to ask what service is available, obviously FND Hope, I know, are putting up a list of trying to develop a nationwide and indeed international list of therapists in different areas. But whilst we're populating that, there's a lot of knowledge amongst ourselves in the UK. So if you're in the UK, I'm happy to be emailed to think about people who are in your area. And if I don't know, I'm pretty sure I know who did know.
Yeah. Are you okay if we share your email address?
Yes, that's fine. No, it's easily searchable online as well. So do get in touch.
Just say somebody did ask a question there in the West Midlands and wanted to know. So that's fantastic. Just one other question in relation, I guess, to the whole area of CBT, and obviously the fact that FND is physically very damaging symptoms for an individual. There's no question about the physical side of things, but the fact that it is the mind that is causing these issues. And I certainly know, I mean, my wife is, in my family, is the one that suffers from FND, and she goes through this conversation with me on a regular basis, so I know that she won't be on her own. But for those patients who are worried of being tagged with the mental brush,
yes,
for want of a better word, how can we go about alleviating that fear that,
Yeah, I think it's a massive problem, and it's partly because there's lots of connotations with psychiatry and psychology. There's then the two biggest. The first one you said, you hinted at there, which is that you're going crazy, you're sort of mad, which is clearly completely not the case. And I think that's a stigma of psychiatry, really, and that it's really in some ways psychiatry is just complex neurology, really. So more, very. So I think that's the sort of. There's not a divide between psychiatry and neurology, and I think FND sort of illustrates that, particularly. But I think it's overcoming that concern that's. But the other major concern is that somehow a psychological thing is something that you have got some control over, or that it's your fault, or you should be stopping it. And that's the other misconception that's particularly difficult. And I think my experience is that when an experienced neurologist or psychiatrist explains the disorder, that you can explore whether those misconceptions exist, and easily, or with a bit of time at least, you can overcome that concern and show that this isn't anything to do with, it's not because you're depressed or anxious or something else. People can have that because those things are common, or you can be depressed or anxious because of the disorder itself. It can have secondary effects like any neurological disorder can. People with Parkinson's and stroke have lots of depression and anxiety. So I think it's just hopefully explaining that it's not those two things which are because anybody would be upset if it's insinuated that that's what's going on. So I think when the diagnosis and the how we understand the disorder explained carefully, I think we can get around that, but it's not an easy task. And I imagine most people's journey to understanding the disorder is it's rarely straightforward and quick. And this is where it can require repeated and different explanations from different people, looking at neurosymptoms.org, chatting on to other fellow patients, and this is where I think you guys have been it's been such a revolution in having support networks, because people have been through that, and sort of people can understand and explain those concerns and say, well, actually, no, I was in the same position. I worried that that's what people were saying, but actually, no, it's not. It's they're not saying that, or it's. But sadly, you still do get quite a lot of clinicians who explain it badly and do. And that's where we've got a lot of work within medicine to make sure that the diagnosis is understood. That lots of doctors don't understand this yet, and to carefully sort of educate people, and starting at medical school, but across the board.
Yeah, and that's, I mean, obviously you have part of your role involved in students as well. Are you seeing that there's more awareness and more interest?
Yeah, absolutely. And we get, I get, so I teach a lot at the King's Medical School. It's one of the biggest medical schools in Europe, and we have a lot of students here. I think it's 300 a year, or nearly even more than that. And I sort of do the teaching on FND, and I find that most medical students are fascinated by this, and also when you can explain that this is functional symptoms occur across medicine, and also but I think there's this misconception that people have, and I think that's why the work, getting media articles and programs about FND are going to be so important, as breaking down that misconception that it's somehow a sort of mental illness, or it's and even worse still, that it's something sort of under someone's control. I mean, and just illustrating the severity and the subconscious nature of this process, I think, is critical. And I think when people are taught well about it, I get lots of inquiries to want to work in the area or do research. So I think we're making sort of great progress, but I think we need to sort of, I think we're quite lucky in London and in the UK, but I think we need to get that message out across the globe, really. And I think it's these sorts of online where we can reach many more people, I think.
Yeah. We've got a question here from Candice. She says, "Hi Tim, I have daily non-epileptic attacks and I'm fully conscious throughout them. Mm-hmm. What actually goes on in the brain during an attack, and what makes my limbs and muscles bend and shake and spasm in the way they do? I am conscious. How is it that I cannot control my body during the attack period?"
Yeah. Well, again, it's fascinating, because that is one of the different things about a sort of non-epileptic seizure, is that sometimes or often is the awareness is retained, but it's somehow there's a disconnection between awareness and control of bodily function. So somehow the system gets disconnected and breaks down. So this concept of dissociation, this term, has been around for over 100 years, and I think it's defined in quite a complicated way. But in another way, I think the way I think about it is it's almost like an emotional clutch that sort of separates your sort of higher functions from your basic functions of like bodily movement. So somehow, there's a disconnection that occurs. So that's really what sort of dissociation is, just a fancy word for a disconnection, really, between awareness and control of any bodily function. And that's why memory can be impaired. That's why movement's impaired. So any neurological function, sensation can be disconnected from awareness. So I think these are fascinating questions. We don't really have much of a handle on what that mechanism is, what's going on in the brain. And the unfortunate thing about seizures is that they're very hard to study. The obvious thing to look at is the functional MRI with that sort of, because what's going on when someone's having a seizure would be a fascinating study. But firstly, the seizures happen, getting someone in a scanner whilst they're having a seizure. Secondly, if someone's got a lot of movement during the scanner, that's firstly the safety issue about being kept still in the scanner, but also the movement. These MRI studies require you to be completely still in a scanner. So somehow, to get meaningful data, the head has to be very still. So it'd be very tricky. It's a very tricky thing to do. But actually this year there have been some what we call sort of MEG scanners, so magnetic EEGs, really, that are sort of portable, that can be sort of they're not that heavy and someone could wear them. So you can actually get perhaps a meaningful data from that. But I think until we're able to the technology improves, I think working out exactly what's going on is going to be very hard.
Yeah. And another question in a slightly different vein, but kind of connected. This one from Lelia, if I pronounce her name correctly. I do apologize if I've got it wrong. But she said, "I think I have hallucinations as I see a man I don't know in my house everywhere. Can't see his face clearly though. I'm not taking any medications, so don't understand the reason. Is this common with FND? So again, it's an experience that's not normal. Could be dissociative, I guess.
Yes, it is. I mean, when that an abnormal perception like that would, classically has two types of mechanism. There's a sort of standard sort of psychotic symptom, which is really so something's triggering a perception when there's nothing there. But I think the most likely, in fact, the only time I've seen it in FND, and it's not a common FND symptom, but it can occur, is in the context of dissociation. So it's and I think such hallucinations are have a slightly different characteristic sometimes to what might occur in, say, schizophrenia or those types of disorders. So there's a different sort of quality sometimes to the hallucination, but they certainly do occur. And unusual out of body experiences, not feeling, these depersonalization, derealization symptoms can exist in some patients as well. So where people feel they're not themselves or disconnected. So unusual symptoms that we'd think of as sort of unusual or features of dissociation. So I think, and I guess it's really how often they're occurring, and their links to other symptoms that you look at quite carefully. But obviously, if they are a major problem, then it's worth looking at treatment. Because sometimes those sorts of things can respond to medications as well. Because obviously, for most patients, medication isn't going to be an answer. But if those sorts of symptoms are common, then you can start thinking about other treatments as well.
Yeah. A question here from Leanne. She said, "Is the disconnection for seizures the same for whole body paralysis?"
For permanent paralysis. I presume that's the question, but yeah.
Well, yeah. I don't know about permanent, but obviously paralysis is an FND symptom where you have that for a short period of time, for a few hours or even a day or so.
Yeah. I mean, again, these are the questions which we'd love to be able to work out, because we just don't know. Is it the same process? But why do certain patients get certain symptoms? Why does a certain patient have one symptom at one phase of their illness and then another develops? And we often see patients. I mean, I've seen many patients who end up with paralysis but had a seizure-like episode at the onset. But seizures aren't their main symptom; it's the weakness that's the problem. So that's quite a common situation for sure. But some people just get paralysis; some people just get seizures. It's and some people have an episode of paralysis and then get seizures later on. So we just don't understand exactly why symptoms sort of pop out at one time in one area of the body or not. And it's sort of fascinating and very important to be able to work that out. But the brain is sadly very complicated, so we got a long way to go to work this out.
The subject of medications popped up a few times just in some of the questions. Fia's asked as well about it, but in terms of your own research and treatment, and we know that a lot of medication that does get prescribed has no effect on FND symptoms.
Yeah.
But what's your view on the use of medication as a whole in terms of a protocol for treating FND?
Yeah, I think at the moment we don't really have any evidence that it's helpful. I think for a subgroup of patients for whom depression or anxiety is a significant problem that may or may not be related to the FND, then I think they have a role. But I think outside of having significant comorbidity with depression or anxiety, I think the role is limited at the moment in terms of what we'd call psychotropic medication. So, just ones that can somehow be fixing something that's going wrong in the brain. But I think there is a role for medication in helping rebalance sleep sometimes, which can be, if someone's got mild depression, not normally enough to think about using an antidepressant, but their sleeping pattern is disturbed and there's a lot of knock-on effects of poor sleep, then sometimes an antidepressant that helps with sleep can be very helpful at treating a low-level mood problem and and treating sleep. And then, once you fix one thing, you can get a sort of positive trajectory of, things getting easier in general. But I think the other big issue is painkillers, because pain is often a massive problem for people with FND. And painkillers have a role, but there's massive problems with painkillers, particularly opiate painkillers, and obviously that they might have a short-term fix of the symptom, but that generally doesn't tend to last. Escalating doses are needed, and then you start to get into problems with side effects of the medication, or being stuck on very high and potentially dangerous doses of very strong and addictive medicines. So it's a very, very difficult thing, because nobody wants to leave pain untreated, but at the same time, you've got to be very careful about creating harm as well. So, it's, and I think, public awareness about the problems with opiates for pain relief is obviously, pretty big at the moment, given the problems happening in the US. But I think, I think most clinicians do, treat things pretty sensibly in the UK, but it can be very, very hard, because there's a temptation sometimes that to feel as a clinician you must do something for the pain, when it might not be the right thing in the long term. So it's a very, very difficult problem.
Yeah, and that's something we'll just come back to that. I just want to remind everybody we've got a few more minutes left before we need to wrap this up. So just the last minute questions in. But Tim, just talking about pain, what's been your own experience in terms of treatment and research in helping FND sufferers overcome the pain? Can it happen?
It can, yeah. I've treated a lot of patients who've been on very, very high doses of opiates, but it takes quite a long time, and often needs to be in a very intensive treatment setting, ideally inpatient, to manage the pain and to get off those medications, because firstly your body is physically adapted to them and dependent on them. But I think there's almost a point where people realize that despite having all these medications, the pain is not, and it's still awful. It's still 8 or 9 out of 10, or even completely debilitating. Yet, despite being on the same doses of opiates that are used in palliative care, very, very high doses of strong opiates. So with massive side effect profiles as well, all the usual bowel and bladder problems that we see. So I think it is very possible to come off them, but it's not easy for anybody, for the patient particularly. And it often requires intensive treatment and specialist input, but it needs to be done very slowly to get somebody off high dose medications. But it's also finding some alternative to treatment as well. There's obviously a bunch of other medicines that can be used for pain. There's also non-medical approaches, and there's the obvious things like TENS machines and acupuncture, relaxation, mindfulness. But somehow it's just getting the whole body. If someone's got paralysis, then getting the body moving naturally again. So if you can treat the weakness and get people moving, then somehow the body can get reconditioned. But the brain, chronic pain does cause a secondary sort of deconditioning of the brain pain pathway. So it can be quite hard to, even though the original stimulus of the pain might have disappeared, the pain is still there and just as severe and real as when there was something causing it. So it can get a life of its own, chronic pain. And it's a big challenge, and not just in FND, but across the board in many severe conditions.
Yeah, which almost begs the question: pain management as if you go to your GP and get referred to a pain management clinic, is that going to be helpful for someone suffering FND? Will they have the right sort of techniques to help in this case?
I think you've got to, really, because that's those are the people, and in the short term when the pain is severe, that's what will work. But it can sometimes be a short-term fix that creates problems down the line. So generally speaking, it's a question of containing the sort of medication escalation, which we see so often, and trying to limit that. And then as soon as is possible, trying to reduce the medications or find an alternative. But it's so hard if you're not having the whole treatment. So that's where we need multidisciplinary treatment where you need your physio, your CBT, your pain management all happening at the same time. So you can, because it's often hard to reduce one thing without there being progress, in other areas. So if you're still unable to move around or have a normal sort of physiological, not moving around, your body's going to remain and move normally. It's going to be painful. So you almost need everything going forwards at the same time, and that's where I think inpatient treatments have a particular role in that, in those sorts of patients.
Yeah. Okay. Well, we've got time for one last question. I think this one might give us the opportunity to finish on rather a positive note, which I always like to do at these. But Victoria has said, do you think there is any way of getting a national compulsory teaching paper for all emergency medicine and general practice professionals to stop the mistreatment we face a lot of the time? The comments of it's all in your head, it will pass, write it out, what do you want us to do?
Yeah.
Et cetera. We spoke about the NICE guidelines earlier on. We've touched very briefly on the multidisciplinary team approach. How's the rollout of that with the different centres popping up around the UK? How has that started to develop now and get more traction?
Yeah, I think that's the sharp end is A&E. That's where, because I think primary care physicians are actually pretty, slightly more knowledgeable, but I think sort of acute care can be a major problem, and particularly outside of specialist centres. But even where we are at King's in London, there's quite a few clinicians who might not have come with any background knowledge or been told about the basics of the disorder, and I think so much damage is done during those times when people are their most vulnerable and most scared, and yet they're treated, even if the words aren't dismissive, it's the body language is sort of please get out as soon as possible, and whereas if you'd had some other type of problem, it would be a very different experience. So I think that is, we're constantly having to sort of try and repair the damage that's done by those sorts of interactions, and I think it's just constant education of going on departments and teaching, in which we do where we are, but also it has to be at medical school level as well. It has to be at nursing college. It has to be I think OTs and physios are generally a bit more rounded in their in their education, but even at specialist centres, there's still quite a few staff who have a very sort of unenlightened knowledge, and it's and I see firsthand what's going on. But I think actually just getting, I think this is where we really want to get sort of it out, programs on national TV, films, anything that explains the disorder, to people. I think because I think once people understand it, then it's their response to patients, and particularly their most vulnerable in time of in A&E will change. But I think it's gonna take many years, and probably more than a decade, I think, before it becomes rare for that to happen. I think at the moment it's still sadly very common.
Yeah. So hope for the future, and
yeah,
you to keep fighting the good fight, as they say.
Yes, indeed.
Well, Tim, I think that's a great place for us to wrap up this webinar. I'd like to thank you very, very much for making the time this evening. It's been great to talk to you.
No problem. Thanks for inviting me on, and apologies for the cat and daughter interruption earlier on. So.
Oh no, it's absolutely fine. To all of our attendees, thank you very much for joining us this evening. Thanks for the great questions, and we look forward to seeing you all very soon.
Okay, bye. Good luck, everyone. And I don't mind being contacted if there's any further questions.
That's wonderful. Thanks, Tim.
Bye then. Bye.